Hello, everybody. It's your Uncle Jim. How you doing? Good to be back here on Kidney Stories with my friends. Um, we're going to have Dr. Kramer on tonight, the president of the National Kidney Foundation. She had a little trouble accessing the show from the network at work. Apparently, the hospital wouldn't let her do it. So she's on her way home, and she's going to try to access us from home. So in the meantime, what I'm going to do is I'm going to flip the back end of the show to the front of the show, and we have a couple of things to discuss. First, I'd like to thank everybody for the support that you gave me while I was ill. I was in a hospital last week. I had some internal bleeding. My hemoglobin was very low, and I was kind of weak and dizzy. So I was in Munster Community Hospital here in Munster, Indiana. They took very, very good care of me. Excellent nursing, excellent doctors that don't have any complaints. Just would like to give a shout out and thank them all for looking after me and making sure I'm okay. Kidney's fine, by the way. My transplanted kidney is doing very well. The creatinine numbers were good. So, and I've tried to be on my good behavior since I've been home. I also wanted to thank everybody. I made a post when I got home to let everybody know that I was back. Terrific response to that post. So many friends and kidney patients and kidney advocates responded. I just want to say thank you to all of you. Your support is overwhelming. It makes the guy feel pretty good. And Martin, thanks, Martin. I appreciate Martin Petro prayers for me. So I appreciate that very much, Martin. So I just wanted to say thank you to everybody and let you know that I'm very, very appreciative of your support and your friendship. The other thing is this week, our friend Steve Belcher put up a petition on Facebook, and I hope you saw it. It's a petition that discusses the fact that DaVita has placed many of their dialysis centers in poor urban areas and not placed them so much in other rich, more affluent areas. And the idea behind the petition is, first of all, for them to clean up their act. If you've ever seen any of Steve's videos, you'll see that there's garbage around those areas. I remember one of them, there was a car that wouldn't start that was in the parking lot. Oh, thanks, Deb. Deb Darcy, glad you're feeling better. I appreciate Deb. And the fact that not only that, but they're always near like a McDonald's or a fast food place. If you're from here in Indiana on Calumet Avenue, you know that between Hammond and Munster, Indiana, which is just like a hop over a bridge, there are 3 dialysis centers, 2 Fresenius, 1 DaVita. They're all, always near the McDonald's, the Wendy's, the Arby's, the Taco Bells, those kind of things. So it doesn't exactly encourage good diet. Hey, my friend Lisa Baxter, how are you, Lisa? Thank you for checking in. So what Steve is asking in that petition is that corporation, the DaVita Corporation, takes some social responsibility. Now, when you study corpse, and I have an MBA, so that's one of the things we spend a lot of time studying. One of the things that they talk about is social responsibility. And what that means in plain English is that when a corporation makes a decision, they can't just take into account their stockholders, the members of the board of directors, the fat cats that benefit. They have to take everyone into consideration, including the public, the people in the neighborhood, and the people that they cater to. For example, with DaVita, that would be dialysis patients. So everyone has to be included in those decisions. And one of the things that Steve and his group have been asking is that there be some public awareness, that there be some billboards, TV ads, magazine ads, ads on Facebook, reminding people about their responsibility toward kidney disease. In other words, early detection and early treatment means that you have less of a risk with kidney disease. I'm a pretty good example of that because I have PDK, polycystic kidney disease. It runs in my family. I've lost 5 members in my family to polycystic kidney disease, including my dad, and I have it. So, for example, because of my history, when I went in and I was complaining to my family doctor, they did a urine test, they did a blood test, I flunked. Okay, a lot of blood in my creatinine, very low GFR, straight to the hospital, spigot put in my neck, on dialysis the same afternoon. But because I was treated early, because I was detected early, I was 25 at the time, I'm 65 now, so 40 years of experience with this. My dialysis was not as rough on me as it was on some of the other folks. And I was able to get on the list and stay on the list to obtain a kidney. My transplant was not as rough on me as it is on some other folks. My post-transplant life has been fabulous. I mean, compared to being on dialysis, this is, I can remember to take pills twice a day, right? I mean, we can handle that. That's not a big deal. Take your pills twice a day, and it maintains your kidney. It keeps your kidneys from rejecting. So a little social responsibility from the DaVita Corporation would go a long way with a group of people that have kidney disease and don't know it. The National Kidney Foundation tells us that there are almost 40 million people, 37 million people in the United States that have chronic kidney disease, and most of them do not know it. And their circumstance when they go on dialysis is exactly the way I described. It's a very slow progressing disease. So, you feel fine, you feel fine, you feel fine, you go on with your life. And then one morning you fall out of bed, you're sick, you can't account for what's going on. You have to call an ambulance, you go to the emergency room, you end up in the hospital. They do the test they should have done earlier on in your life, and by the afternoon you have a catheter in your neck and you're taking your first dialysis. This is not the way to do this, and they should not be promoting or fail to promote the fact that people can avoid this, that there are things that people can do, and they're very simple tests. I mean, you're talking about peeing in a bottle and having them draw a little blood for them to determine this. And unfortunately, because kidney disease is kind of silent and it mimics a lot of other diseases, this is the only way. Hey, Jared, how you doing? Jared Brown checking in. Hi, Jared. This is the only way to detect this. And see, these guys have an economic stake in the outcome, so they are not taking social responsibility. They are not considering everybody that they should consider, like the people in the neighborhoods where they put their centers, right? I live in Hammond, Indiana. That's an urban area, predominantly Afro-American, predominantly other than Caucasian type people here. It's in my building, I'm a rarity. All right, there's like maybe 2 or 3 of us, and everyone else is a minority. And there's 700 people in this building. So, and like I said, 3 centers, a score of fast food restaurants, the whole 9 yards. Just like Steve describes it. These people should take some social responsibility. They should tell this group of people where they put their centers, where their friends and their neighbors, and they should tell them, look, this is what you need to do to avoid ending up here. This is what you need to do to avoid ending up on dialysis. This is what you need to do to lessen the impact of chronic kidney disease. So So it's not so bad later on because, when I was in dialysis, and I've been in two different centers here in Northwest Indiana in my life, one in Crown Point, Indiana, one in Dyer, Indiana. And anytime I traveled at that time, Washington, D.C., out west in Las Vegas, Texas, New York, you always got to dialyze when you're out of town in case, people don't realize that, arrangements have to be made ahead of time. Any center that I was ever in was packed, jam-packed. I mean, you have to call ahead 6 weeks ahead when you travel just so you can get a chair. And they kind of control, what shift you're on. You could be early in the morning, you could be late in the evening, you could even be overnight, what they refer to as nocturnal dialysis. So these guys should take some social responsibility. They make a ton of money. I mean, think about this. Medicare does not negotiate medical bills. They don't try to negotiate them down. So whatever these groups want to charge, Medicare pays it. Medicare pays 100% of it. Okay, so that's why Steve is out there, why you see him out there on Sundays, and you see him pointing to the DaVita signs, and you see him walking around the building showing you the condition of the buildings. They should tell people in advance. They should tell people in advance, this is the situation. Unless you want to end up with us, you need to go in, you need to get tested, you need to see your physician, you need maybe to alter your lifestyle, you need to take high blood pressure medication, you need to look after your diabetes. Diabetes and high blood pressure are the number 1 and 2 causes of kidney disease. You need to do this now while you still can. Okay, see, I was so lucky. It's the only way I can characterize it. I was so lucky because of my family's history. My family doctor did not mess around, and not only did he refer me to a nephrologist, but he also referred me to his old medical school, IU Health, down in Indianapolis, and I lived in Valparaiso at the time, so that's 2.5-hour drive. But it was very, very important because when I went down to Indianapolis, and that is a teaching hospital, and by that I mean they have doctors who are professors that teach other doctors how to be doctors. They have nurses that they teach there. They have techs that they teach there. They do dialysis there. They do transplant there. So, I was in really, really good hands. I had some really, really good physicians. And I mean, the first thing they did was they put me on high blood pressure medication because I had high blood pressure. And of course, I didn't know that at the time. They put me on a kidney diet. They had me, because I'm computer literate, they had me put together a program where I could show them what my blood pressure was, what my temperature was twice a day, what I was eating, diet, so that, the dietitian could sit down and say, Jim, don't eat that, no more steak, some salad, something green, right? So, but that saved my life. That made the rest of my kidney life easier. Okay. My doctor, Dr. Black was his name. Dr. Black took responsibility. He said to me, you need to do these things. And I did. Now, I was diagnosed when I was 25. I didn't end up on dialysis until I was 58. And they would have me come back every 6 months or so. And, we go through the whole thing. They draw blood, pee in a bottle, I get weighed, they take my temperature, they take my blood pressure, they go over the chart with me that I prepared. They gave me medication. I mean, they took real good care of me. So I was able to stay off of dialysis a long time. When I was in dialysis, these people would come in. They come in gurneys. They come in wheelchairs. They come in walkers. Many of them had to be carried in. to dialysis and put in a chair. In the 4 years that I was on dialysis, I saw 4 people die on my shift. One lady passed away. She couldn't have been more than a dialysis chair away from me. Okay, a short reach, maybe 6 feet, 7 feet. Okay, that didn't happen to me. I was lucky. I was lucky because somebody took responsibility to inform me, to teach me, to let me know what was going on. They weren't worried about making money. They weren't worried about their stock. They weren't worried about what Warren Buffett was going to think. They were worried about my health. That should be the primary concern. Think of the 37 million people that have chronic kidney disease and do not know it. The majority of those people do not know it. This is horrible. Steve is right. Something has to be done. Okay, they have to take responsibility. They make a heck of a lot of money off of kidney patients. They don't have to negotiate their price. They just pay it. Okay, Medicare just pays it, 100% of it. All right, so on my page, you'll find it. I'm sure you'll find it on the Urban Networks page. Seek out Steve's petition, sign it, share it on Facebook, share it on Twitter, share it on Instagram, pass that baby around. I personally would like to see 500,000 signatures on that petition. I would like the kidney community to stand up and to say, this is important, because I'll tell you why. You want to know why it's important? What about your family members? What about your children? What about your friends? What about your co-workers? What about the people that you know and you love, right? I don't know how you feel about it, but the way I feel about it, I have a son. My son's in his early 30s. He lives in Cincinnati. He works for the Cincinnati Reds. He does authentics for them, autographed baseballs, jerseys, stuff like that. And most of my adult life, I feared for the fact that he could inherit my disease. Okay, now he didn't. His mother didn't have it. I had it, 50-50 chance. His number came up good. He doesn't have it. But I mean, think about this. If you could prevent somebody from going through the things that you have gone through as a kidney patient, because I don't know about you, but I should glow in the dark. I've had about every test known to man. Some of them, while I was on the waiting list, I had to take twice because the hospital in Chicago, Rush Medical, would not accept a test from IU's tester or from the tester at the University of Wisconsin. They had their own testing. They did their own blood work. Everything they did was the gold standard. No chemical stress test, baby. You got an angiogram. They stick that thing all the way up through you just the way you think, and then afterwards you sit still for 6 hours watching the clock, wondering why you were ever born, just to find out if your heart's okay. But the point is this: if you could prevent your friends, your neighbors, your loved ones, your family, the people that you work with, the people that you know, your friends on Facebook, your friends on social media, wouldn't you want them to know about this? Wouldn't you want them to avoid this? Do you not want people to be aware of the risk of the 9th leading killer in the United States of kidney disease? So, my friends, let's make sure that people know about this. Let's make sure that people understand why Steve Belcher is out there on a Sunday standing in front of a DeVita with a broken down car, with beer cans in the back, with vials of whatever it was in the back. Chair and blankets in front of one of their buildings that looked like somebody peed on it. Okay, why does he do that? He's trying to make them accept their social responsibility to the public, to the people that they make money off of, to the neighborhoods that they choose to put their dialysis centers in. Let people know. Take the tests, right? Take the tests. Pee in a bottle, let them draw a little blood, find out the truth. Are you a diabetic? You're at risk. Do you have high blood pressure? You're at risk. Do you have heredity? Like I have, okay? You're at risk. You're at high risk. That's not even to mention the COVID thing, okay? Not even to mention that. We're going to talk about that tonight too, hopefully when the doctor comes. But, you know, you could be on the high risk end of this. So sign the petition, pass it around, tell people about kidney disease, tell them your kidney story, right? My name is Jim Myers. I'm 65 years old. I have polycystic kidney disease. I was diagnosed when I was 25. I went on dialysis when I was 58. I was transplanted at the age of 62. I'm 65 now. I just celebrated my 4th anniversary as a kidney transplant patient. Simple, right? Kidney story. Tell them your kidney story. Tell them, you know, the next time you go to your doctor, the next time you have a physical, the next time you have a checkup, insist that your physician draw a little blood, have you pee in a bottle, and check your creatinine, check your GFR, check to see if you have kidney disease, check to see if you have issues. You know, that early check in my life, that early detection, that good early care and treatment is the only reason that your Uncle Jim is still sitting here tonight, still speaking to you. That's it, man, okay? Just being real level with you. So I see, you know, I see Steve out there, I see him doing these things, I see him making these statements, I see him working. This guy is the hardest working guy in kidney land, man. I see him out there, they're working, and I constantly see in the comments, why is he doing this? Why is he doing this? Why is he out there on a Sunday? Why didn't he take the Sunday off, right? It's Sunday. Well, why isn't he home? You know, why isn't he taking it easy? It's because he knows, like I know, like you know, that this is an insidious disease, that people are not aware that they have it or might have it, that it's a very, very simple check. It's an easy check. 10 minutes and you're out of it. Okay? It's not a big deal. And you need those, just so you know, those of us that have kidney disease, it's not like, you know, they do this the first time and they're, okay, Jim's got kidney disease. I mean, they draw blood. They have me pee in a bottle every time. Every time I go in to see the doctor, every single time I go to my transplant center, right? They take blood from me. They still check. They want to know my levels. This keeps me healthy. Then they know, can you see? Then they know what medicine to give me and how much. And see, this is my anti-rejection medication for my kidney, right? They know what they're supposed to give me. They know how to treat me and care for me. You're better off knowing than not knowing. Knowledge is power, my friends. Knowledge is power. And you're better off being in the know about your kidney disease, because then you can take care of it. Then you can monitor it. There's no cure for it, okay? I'm not going to lie to you. There's no cure. Even when you get a kidney transplant, that's what they call renal replacement therapy. It's just another form of treatment that takes the place of dialysis, but it's a much nicer one between you and me. Okay, that's my opinion. I know there are some people that really like dialysis, that enjoy their dialysis, that are concerned about the costs of anti-rejection medication after they're on dialysis, et cetera, et cetera, et cetera. Those are all legitimate concerns. And I certainly don't want to talk anyone out of their dialysis that wants to do it. But I'm just telling you my personal opinion. Transplant is better. It's been a much better way of life for me. But as advocates, one of the things that we have to do is to concentrate and raise awareness. We can't just count on people like DaVita. We can't count on people like Fresenius. We can count on people like the National Kidney Foundation, like the American Association of Kidney Patients, like the American Kidney Fund. Those are a few of the groups I belong to. Like, yeah, Kidney Warriors globally. Yeah, count on Kidney Warriors, you can count on this network. Okay, you can count on the Urban Kidney Network to tell you the truth. All right? So we can be kidney giants. We have to do our part. We have to raise awareness about kidney disease. We can't count on anybody else. We have to count on ourselves. All right? I bet you've heard this expression before. You have to be your own best advocate. Right? You have to be your own. I just got out of the hospital. You know, if there were things that I didn't want them to do to me, I have a right to tell them no. All right? So, you know, you have to be your own best advocate. You have to look out for yourself. You have to educate yourself. But in the meantime, these people that make so much money off of us, they have a responsibility too. Now, it's not, they don't have a product like cigarettes where they knew it was bad. They injected it into the stream of commerce. It made a whole bunch of people sick while they sat silent and people got cancer and died. So litigation, not going to work here, okay? Petitions like Steve's will work here. As long as people like you and me support it. Okay? So find it, share it, sign it, pass it around, make it known. There is no good reason why we can't have a number of signatures on this. And, you know, nobody works harder than Steve Belcher. I'm telling you, I'm a hard worker. This guy is a real, I'm too old to work like he does, okay? But he is a hard worker, and he has made this point over and over and over and over and over and over and over again. Okay? This is not personal. He's not discussing his personal issues. This is the truth. Okay? So please sign the petition and pass it around. Now, one other thing I want to talk to you about. There's a petition from the National Kidney Foundation as well. And I am asking you to go to the NKF's website, to go to the National Kidney Foundation's page on Facebook, to go to the National Kidney Foundation's page on Twitter. If you can't find it, contact me, right? My email, kidneystories@hotmail.com. And you guys know I'm all over Facebook, right? So you can find me, and I'll send you the link. And you can sign that. This is important because this addresses issues for kidney patients, advocates, family members, caretakers, to share some of these important initiatives, like making sure that dialysis patients have access to personal protection equipment, like making sure that our healthcare providers have access to personal protection equipment so they, you know, don't run out, right? And, you know, I was in a hospital recently, right? So I noticed that when I was there, and I've been asked to write a blog about this, so keep your eyes out for that, okay? I noticed when I was there that every time a nurse or an aide or a lady that's picking up the trash, a social worker came into my room. They were masked, they were gowned, they were gloved. And they came in, they were like gloves, plastic gloves in a box in the room. They put on the gloves before they talked to me, touched me, anything. They always maintained a good social distance, 6 feet. They always had a mask. Some of them had a mask in the shield over their face. So, you know, even in a non-COVID area, it's very important that they have access to this personal protection equipment. That's for your protection, right? You understand that, right? One of these babies, and I got this through the mail. Okay, I know it's a cheap one, but you know, it works for me. I've been outside like 5-6 times since it started, so you know, I try to take care of myself. But you know, one of these, right? And the other thing is the NKF wants to prioritize COVID testing. Now, when you have a country with as many people as we have, and you have a pandemic like this, and you test between 1% and 2% of the people that are involved in this, that ain't good enough. Okay, here, let me show you something else. Wow, this is from my building. Okay, I don't know if you can see that, but they're doing COVID testing in my building. I've been through it once already. It's not a big deal. They take a cotton swab, they stick it up your nose. It's over in a matter of seconds. It's just not that big a deal. But we need to prioritize testing because kidney patients, people with kidney disease, people on dialysis, people with kidney transplants that take immunosuppressants, right? We're in a higher risk group, my friends. We're in a higher risk group. So because of that, testing has to be, we need to know, right? We need to know if we have it or if we don't. Do we need to quarantine or do we not? Do we need to call our transplant center? Do we not? Do we need to call our dialysis center? Do we not? Do we need to be segregated when we're in dialysis or isolated when do we not? We need to know because we're at high risk. So testing for us has to be prioritized. Testing patients in nursing homes, doesn't that make sense to you? Right? Doesn't that make sense? I mean, when they talk about these outbreaks, areas where people cohabitate, live together in close areas, that's how this spreads. They don't even know the numbers in nursing homes, which is unbelievable that they would not have some idea how bad this is. But those people should be tested, right? I mean, just because you get old doesn't mean you're discardable. That concept is so foreign to me. All right, elective surgeries, critical elective surgeries should go forward. Right, things like if you need a fistula, right? If you need a graft, if you need a port so you can do peritoneal dialysis. These have been termed like elective surgeries, and some of these have been delayed for some people, which, you know, a catheter, right? I've been through this catheter thing twice. Do you know how long it took them to put in my catheter? And I was awake the whole time. It couldn't have been more than 20 minutes, right? Both times. And coming out is even easier. It's like, you know, they take the stitches out and pull the thing out and it's done. So, and Steve has shown you those catheters, right? So nothing to be afraid of. But at any rate, some of these surgeries have been canceled. That's delayed people from going on dialysis. That's hurt their health. That's delayed people from going on hemodialysis using their fistula, which is the preferred method. Why? Because the catheter goes in to your heart. And of course, if you have an infection, that could go to your heart. And this is not a good thing, my friends. This is a bad thing. We do not want that. So, peritoneal dialysis. If you prefer to dialyze at home during the time of the COVID crisis, you're probably safer than if you're dialyzing in a crowded dialysis center, right? I mean, that makes some sense. A lot of people want to dialyze at home now. So those elective surgeries, we want them to go through. We want them to be done so people can do their dialysis, so people can do their home dialysis, right? We want people to maintain good health, to feel better. I don't know about you, but before I went on dialysis, there was one period of time where I knew I was real sick, okay? And I knew I was not doing well. And I believe the expression is Uncle Jim was in trouble, all right? And my phone was on my bed. I was on my bed. I had my head up at the head of the bed. My phone was near the foot of the bed. I wasn't strong enough to easily reach my phone. Okay, that's how sick I really was. All right, and I began to panic because I thought, man, I can't call 911 without that baby. So it's very, very important that these things be done. Meds. The National Kidney Foundation's petition talks about having 90 days worth of meds. I think the doctor's here. That's good. Whew. Okay, bring the doctor on, Steve. We're ready. 90 days worth of meds, right? In this period of time, you don't want to be running back and forth to the pharmacy. You don't want to have them mail you 30 days worth of meds for a month in case something gets lost in the mail or things go bad. You want to have enough medication to last you for a while, to last you 90. Doc.
Hey, thanks.
You're up against talking ad-libbing for 40 minutes. Oh my God. Oh my God. How are you tonight?
You have your pin on. You have your Kidney Giant pin. That's awesome.
That's right. I'm a Kidney Giant.
Oh, you are truly a Kidney Giant too. You so deserve that pin. Out of all the people I've given that pin to, you are the Kidney Giant. Absolutely.
Oh, well, thank you very much. And I'm glad you're with us. Can you hear me okay?
Yeah, can you hear me okay?
Boy, yeah, you kind of froze up there for a minute, but I think we're all right now. So, okay. I had this long introduction plan, but I'm going to make it short and sweet for the benefit of time. This is my good friend, Dr. Holly Kramer. Dr. Kramer is the president of the National Kidney Foundation, and anything in nephrology that could be done, trust me, she's done it. So we're very, very pleased to have you with us today. Let's get into the questions. Okay. Tell me a little bit about your connection to kidney disease. Why did you go into nephrology, and as deeply as you have? Can you explain that for us, please?
Yeah, well, so my mom was a dialysis nurse, and she actually started, helped to start one of the very first dialysis units in Northeast Indiana around Fort Wayne. And so back then, this is like 1978, 1979, she used to travel to different dialysis units, you know, like Churubusco, Roanoke, Indiana, places like that, these little small towns, and we would visit people's houses, and I saw lots of big dialysis machines that were on blue shag carpet, and met many patients. And there were a few patients that actually did well on dialysis, and I got to be friends with them, and they sent me notes and stuff, and lots of encouragement as I was early in my high school career. And everyone I was always saying, you really have to do something to help these patients and prevent end-stage renal disease was really kind of the thrust of it, and it's what my mom really wanted for me to do in my life. And so I ended up going into nephrology, and it's been such a blessing. I've just really have loved it. But I remember all those patients, and I really want to try to use my time that I have here on this earth to do what my mom wanted, which was to help prevent renal disease.
Well, we're very glad that you did. We're very, very, very glad that you did. Now, you told me I have to ask this question right up front, so right from the jump. Talk to us a little bit about the importance of patient advocacy in persuading legislators to make changes. Talk about the importance of why patient advocates are needed.
I'll move my chair a little bit so I don't get my kids in here. So it is incredibly important because other organizations have really made big strides for patients, like the American Diabetes Association or the American Lung Association, and certainly people in the 1940s and 1950s who advocated for research for cardiovascular disease that really helped to grow research investment in their disease. Vice President Joe Biden, was a great advocate for cancer research, for example, and end up getting, a lot of extra money allocated to cancer research, which has really had a tremendous impact on oncology. And many patients that I see that probably would have died 10 years ago now are surviving and being cured. And so we really, we lack that major research investment in kidney disease. We've just consistently lacked it for decades. And what people are going to really remember are patient stories or families of patient stories. So if I go into a congressman's office and I talk about, the importance of kidney disease, I'm just a talking head. They're not interested in what I have to say because I haven't experienced kidney disease. I don't have a family member that has experienced kidney disease. And so the stories that are going to move Congress and senators to invest in kidney disease are the patients and the patient's families. So it's the voice of the patient and the voice of the patient's families that can really help get Congress to move and make changes. And what we really, really need is research investment, major research investment. I mean, hundreds of millions of dollars a year added on to what we are already investing in kidney disease research. Because I can show you time and time again, when you put a lot of money into research investment, America is really good at finding innovations for that particular disease, whether it be cancer, cardiovascular disease, skin diseases, lung diseases, you name it. If you put research investment in there, you will find innovation, you will find cures, and it can really make a major impact on kidney disease.
Wonderful, wonderful. I wanted to ask you a question that's kind of off the books. It was something that I noticed after we talked yesterday. What is the NKF Patient Network? Some kind of registry or something? What is that about?
So the patient registry is a big investment from many people who have provided funding to create a patient network where patients can actually log into this patient network and they can provide information about trials that they might be interested in. And then they can be contacted to enroll in clinical trials across the whole U.S. And in addition, if you allow the Patient Innovation Network to obtain your data, then that data can be put into a big pool that can actually be utilized for research. So for example, many kidney diseases are uncommon and they affect only a few thousand people across the US every year. And it's very difficult to do clinical trials in that if you're just looking at one particular area, like if you're just looking at Minnesota or you're just looking at the Chicagoland area, it's still, even with that big of a population, it's hard to do a clinical trial. So you really need to pool centers across the entire US to get enough people to have enough power to detect differences for a particular treatment for a particular disease. So that patient network is going to allow patients to register on this network and be contacted to be involved in clinical trials. So it's really exciting, and I think it's going to revolutionize research for kidney disease.
Looking forward to it. You know, please keep us updated on what's happening with that.
Yeah.
All right, Doc, let's talk about the kidney transplant waiting list for a minute. There's almost 100,000 people on that list. Every month, you have told us that they add 3,000 people. We lose 12 to 13 candidates every day that are waiting on that list. Discarded organs that could be usable have not been used. Your words, huge silos of healthcare providers who don't talk to each other, and therefore things like donor chains, paired donation, frequently don't come off because of conflicts preventing access. What can we do, Dr. Kramer, to make the kidney transplant list shorter so we can maximize kidney transplants in the United States?
So the National Kidney Foundation, along with like the American Society of Transplants and American Society of Transplant Surgeons, they are working together to try to improve the efficiency of the transplant process. So that comes from the organ procurement process to organ allocation, and also to try to increase the number of centers that utilize those chains for living kidney donation. As far as the amount of organs that are discarded and not utilized, we really need to have a better communication between the practicing nephrologist, the patient, and the transplant nephrologist or transplant surgeon, so that we are all on the same page as the type of organ that could be accepted for the patient. And I think that patients really need to have better education about the reason why you might want to accept an organ that may not be absolutely perfect. So I think there needs to be like better communication that goes down to the silos of medicine where we're not really communicating with each other. And I have seen where some patients have kind of developed different methods of trying to improve communication across these silos. But so there's many, many steps that we need to take to increase the efficiency of organ procurement and organ allocation. And people are working on that as we speak. And I think 10 years from now, we're going to see that wait list is less. Whether or not it's going to be 25% less is what the Advancing American Kidney Health Initiative wants. But I think we can make many, many changes at different levels to improve that. And certainly the chain for living kidney donation is something that's really unique to certain centers across the US. And it requires special consent forms and might be a little bit an issue as far as the organizational structure for doing those chains. But it's something that certainly can be utilized at many more centers than what it is. And so that's one of the main things that many of the transplant nephrologists that we've talked about, that they think that that's a main way that we can increase living kidney donation and use of living kidney donors, is by increasing the utilization of those chains at many more centers across the US. That's probably actually one of the easiest things that we can do to increase kidney transplantation.
Okay. Doc, one of the things that we've talked about on the program before is the immunosuppressant bill that the NKF is sponsoring and pushing. And the fact that Medicare only pays for the first 36 months after your transplant for immunosuppressants. You have mentioned to us a study was done that if Medicaid paid for all 10 years, for a decade's worth of immunosuppressants, Medicare could save close to $300 billion. And I know there are estimates that are higher than that. Can you please explain how Medicare can save on the cost of immunosuppressant medications? Because this is something,
Sure.
you know, people try not to get transplanted because of these costs. So we want to alleviate those fears. What can we do,
Right.
Doc?
Right. So if Medicare would pay for the medications past the first
Breaking up
36,
a little bit.
then if
Go
people
ahead.
would pay,
I hear you.
okay. So if immunosuppression is paid for the entire time that a person is on has the kidney transplant, then you would have a longer shelf life of most of these kidney transplants. I mean, many people start to ration their immunosuppressants after the first 36 months if they have a high copay or difficulty in paying for their medications. And so then that leads to sort of like a smoldering rejection often, where it may not go detected for many years until it's too late. And then they end up needing a second or a third kidney transplant. And so that person just goes back on the waiting list, right? So then that means that you have more people who are then waiting for a second or third transplant. If we could just get more time out of that first kidney transplant, then people aren't going to be going back and getting the second and third, and you have better opportunities for people to even get their first transplant. So that's the reason why it's cost saving, because they know that the cost of immunosuppressants is a major issue for most people who get kidney transplants. And so I think we've seen great response to the immunosuppressant bill, and we think that we may be able to actually get this passed at a national level this year, and many states have passed it. So we've had a tremendous response. I know, I think Oklahoma might have been like the first state, or maybe it was Idaho. Idaho was the first state to pass the immunosuppressant bill, and many other states have subsequently passed it because of the actions of like the local National Kidney Foundation organization. So I think that we can get this passed this year at the national level, because it is cost saving. It's cost saving. It makes no sense to give someone a kidney transplant and, oh, we're not going to pay for your medications. So we really
And then you
need
end
to
up
change.
back on dialysis where they pay 100% of that, and the cost of dialysis is so high.
Right.
It doesn't make sense.
Right. Yeah, it makes no sense at all. Yeah. So everyone who has heard this, like on the Senate Budget Appropriations Committee, when they gave testimony, Matt Cooper gave testimony, everyone who was on the committee just said, we need to make this happen. You know, it was actually like one of the few times you saw a unification of the Democrats and Republicans. Like everyone agreed that this is a win-win
Parties, right. I remember the chairperson saying that this should happen.
Yeah.
So, Doc, are you still there?
Yep.
Hello. Okay.
I'm here.
She's kind of frozen up a little bit, Steve. Let me ask this. There are 37 million chronic kidney disease patients in the United States. 80% of those dialysis patients are catheterized when they started dialysis, indicating that this was emergency treatment. In other words, it's just like I talked about at the beginning of the show. The poor guy fell out of bed, and the next thing he knows, he's being catheterized and put on dialysis. Medicare expenditures for all kidney patients is $120 billion with a B dollars. CKD is 34% of the Medicare budget. I've heard you in your plenary talk say this is not sustainable. As advocates, how do we make people more aware of the benefits of testing for CKD, the benefits of early detection and treatment? What can we do to make the public more aware of what's going on?
Well, first of all, we really need to get kidney disease in the minds of more Americans, right? And that's the reason why part of the Advancing American Kidney Health presidential order was to increase public awareness of kidney disease. So most people just even forget that organ exists. So the National Kidney Foundation did launch a public awareness campaign just to get people thinking about kidney disease and to get high-risk people to be screened for kidney disease. But because of the pandemic, that awareness campaign had to be paused, and we're hoping to get that campaign restarted sometime in the fall. And certainly the COVID-19 epidemic has even broadened the importance of kidney disease and really emphasizes the timeliness of people being aware of kidney disease. And we can talk about that a little bit later. But so that'd be the first thing, is just really increasing awareness of kidney disease. We really lack clinical trials that show the benefits and cost effectiveness of screening for kidney disease in certain populations. And so right now we're really just focused on screening people who have diabetes. But what really should happen is anyone who has a family history of kidney disease should be screened for kidney disease. Certainly if you have, really poorly controlled hypertension, if you have diabetes, you should be screened. So there's many groups who should be screened and who are not being screened. And even among people who have diabetes,
hypertension, diabetes,
right?
People
so even
that have
right, and even the
like
people
myself,
who have diabetes who should be screened, they're not being screened adequately. They're not getting the full complement of tests that they should be getting. And if they are getting it, they are probably not even getting it annually. And then if we get the test, they're not getting like the diagnosis that, hey, your GFR is low or your albumin to creatinine ratio is high. So the laboratory data then are not being translated to an actual clinical diagnosis and treatment. So as I said in the plenary session, it's about 85% of people who have kidney disease still to this day are unaware that they have it. So we've made
that they have or could have.
Right. So I think,
Doc,
I think
let's talk about funding for kidney research. You have made the point that there is lack of adequate funding for kidney research. For example, the NIH has invested in research for cardiovascular disease, and there's a decline of 80% in that disease. Research in cancer has saved 2.6 million lives since 1991. Cancer research is funded tenfold more than kidney disease. There are 37 million people with CKD. There are 34 million people with diabetes, but funding for diabetes research is about twice what that is for kidney disease. You've told us that the low levels of kidney research reflects in that nephrology has the lowest levels done. And the effect of that is that there are less researchers, there are less less doctors going into nephrology. Morality is not improving. The survival of kidney patients is not improving. CKD mortality is up 65%. Cancer is down 450%. Cardiovascular is down 800% between 2003 and 2013. Doc, how do we get the funding for kidney disease up? How do we encourage more research? How do we get more researchers like yourself? How do we get more nephrologist doctors to take care of people like me? How do we do that?
Well, the answer isn't in me. The answer is actually in you and people like you. So this is where patient advocates can make the difference. So if I go to Congress and I say, hey, I do research and it's really hard to get the funding to do research, they don't want to hear it. They I'm just a number. But if you go to Congress and you tell them your story and tell them how you think that if we invested in research, we could prevent more people from going through the same thing that you had to go through, they'll listen to that. And that's what we need. We need people who have suffered with kidney disease and who have survived kidney disease, or family members who have seen a loved one on dialysis, or people who have gone through a kidney transplant. We need you to talk to your senator and talk to your congressperson about the lack of research funding for kidney disease. And it's just as simple as that.
For kidney disease.
Oh, absolutely. Absolutely. It's kidney disease has The lowest amount of research, yeah.
Okay, are you there, Doc? Did we lose you?
Nope, I'm here.
Can you hear me? Okay.
Yep.
All right. Another question off the beaten path. Talk to us a little bit about the Virtual Kidney Patient Social Summit. What is that all about?
The virtual what?
The Virtual Kidney Patient Social Summit. I've been getting mailing on it lately from the NKF. Apparently, you guys are doing an entire summit online. Is that correct?
I see. Okay, that's the first I've heard that it's going to be completely online, but that makes sense. So I think it's just, you know, in the past we had a kidney summit where you're trying to advocate for kidney disease, and usually that's done in DC. And of course, last year we had to cancel it. It was in March. It was like around March 15th, I think. And so all of that was like canceled at the last minute, and no one could go. And that was a real problem because we were really hoping that we could really push our immunosuppressant bill through at that time. But so yeah, so I think if you can, if you have time to do it virtually, I think that's great. And maybe having it virtual will allow more people to be involved. And they can, and I would encourage everyone to be involved in this virtual summit, because if you haven't done advocacy work before, then you can learn how to be an advocate for kidney disease. So I hope everyone does join this. I didn't know that it was going to be virtual, but that totally makes sense, and I think that's great.
Surprises from Uncle Jim tonight.
Yeah.
Let's talk a little bit about the May 21st letter that the NKF and the American Society of Nephrologists sent to Secretary Azar with Health and Human Services, and your signature appears on that letter, so I know you know what's going on. The letter talks about kidney patients' needs in light of the coronavirus and the steps that the administration needs to take to help kidney patients. Is that a fair statement?
Yes. Yes.
Okay. One of the things that the letter talks about is the need to treat CKD patient, end-stage renal disease patient, and transplant patients as quote-unquote vulnerable to COVID-19. Can you please talk to us about that? Why do you consider kidney patients to be vulnerable to the virus?
Well, definitely patients who do dialysis, do in-center dialysis, they're going to be traveling to and from a dialysis unit. So they're constantly exposed to healthcare workers and maybe to travel personnel. So they're leaving their home several times a week. So every time they leave their home, of course, they're increasing their risk of being exposed to the SARS-CoV-2 virus that causes the COVID-19 disease, right? So, so they're very vulnerable. But we also know that kidney disease and people with end-stage renal disease, or even earlier stages of kidney disease, and patients who have a kidney transplant are at higher risk of developing, severe outcomes, having the virus really be difficult to fight against. So it might require hospitalization. People may get very short of breath and maybe require oxygen. You could also develop kidney injury if you're not on dialysis. Your kidney function could get worse if you get the COVID-19. So that's the reason why we call them vulnerable. So not only that the dialysis patients have a higher risk of being exposed to the virus, but then that if you do get COVID-19, that you could have a hard time fighting the virus. So yeah, we're strongly advocating for the Department of Health and Human Services to really look at people with kidney disease as a population that should be strongly protected.
Wonderful, wonderful. I've noticed that some of the COVID patients, they tell us develop kidney disease, and I noticed that out of New York that you have told us 20 to 40% of the COVID emergency room patients develop kidney failure and need emergency dialysis. That's also a consideration too, is it not?
Yes. So acute kidney injury is really common in people who are sick enough to be hospitalized. So if you look around the intensive care unit, you might see at least maybe about 10% up to even 40% of those people who are in the ICU have kidney problems. And some of them even require dialysis. And I was actually talking to some people at Mount Sinai this morning, and they're saying how, they're seeing a lot of people who were discharged from the hospital who now return for follow-up. And many of those people now have chronic kidney disease because of COVID-19, right? So anyone who already has some pre-existing kidney disease, you always worry about losing more kidney disease, more kidney function, right? You want to try to maintain the kidney function that you have so you don't need dialysis or a kidney transplant. So we're really concerned that if you get COVID-19, it would further damage your kidneys.
Excellent. The letter also talks about mortality rates for kidney patients. Dialysis patients who develop the virus in the range of 10 to 20%. Kidney transplant patients as high as 30%. Can you tell us, why is this significant, and what is the National Kidney Foundation urging be done about it?
Well, certainly what we're urging patients to do is to continue to stay safe. So even as states reopen, really think that patients who have kidney disease, especially if you have a kidney transplant or if you're on dialysis, do not start going, shopping, when you don't need to. Don't go to restaurants and bars, and you need to continue to quarantine yourself as much as possible, unfortunately. So I've had patients ask me, hey, can I go on my Caribbean cruise this summer? Can I go on a plane and go visit my sister in California? And the answer is no, because of the vulnerability of patients who have kidney disease to having bad outcomes with COVID-19. So unfortunately, you have to still maintain social distance and continue to quarantine as much as you can.
Okay. No, Steve, my mic's fine. Can you hear me, Steve? I hope so. Can you hear me, Doctor?
Yeah, it's a little different, but I can still hear you.
Okay. Should kidney patients be included in this vulnerable individuals group as part of the special population that's susceptible to COVID-19? And if so, why?
Why should patients with kidney disease be considered the special population?
Yes, ma'am.
Yes, they should, because we know from data even from Wuhan, China, in addition to data from like New York that has come out, that there's a high mortality rate, just like you said. Patients who are on dialysis, the mortality rate might be 10 to 20%. Patients with kidney transplant might even be a little bit higher because you're on immunosuppressants. So yes, so anyone with kidney disease should be considered a special population, vulnerable population, and they should continue to try to quarantine themselves as much as possible.
The things that are recommended in the letter: masking, social distancing, shelter in place. Can you talk to us a little bit about why kidney patients should continue to shelter in place?
So the shelter in place is still really important, just because of the extremely high risk of having bad outcomes, meaning that you'd be hospitalized in the intensive care unit, could lose kidney function. Like if you have a kidney transplant, you could lose your kidney transplant, or you can lose the kidney function that you may have. Dialysis patient, we certainly worry about like needing intubation or even death with COVID-19. I mean, it's extremely serious. It's not something that you should take any risk. So if you do have to go out to the grocery store, I would suggest try to go during times when it's going to be less populated. Go like late at night or really early in the morning. Definitely wear a mask, and then make sure like you wash your hands real good when you get home or as soon as you get in the car. I always put a lot of hand gel as soon as I get in the car. But you still cannot go and hang out with family. You can't go out to a restaurant, or you shouldn't go out to a restaurant, shouldn't go to the movie theater, all those things. You need to continue to shelter in place because of the high risk of bad outcomes if you do get infected. I'm not saying that everyone has a bad outcome, but just the risk is just so much higher if you have kidney disease.
Doc, for our friends that are dialysis patients and kidney transplant patients, we have a lot of contact with healthcare personnel. How do we continue to isolate and keep a proper social distance on one hand, and on the other hand, do things like take our dialysis or get our blood drawn as kidney transplant patients? How does that work?
Yeah, so I think that the risk is a little bit lower with the healthcare personnel because, every time I walk in the door, they screen me. I'm also required to wear a mask, and I also wash my hands a lot. So those 3 steps really help to mitigate the risk of getting exposure to the virus from a healthcare personnel, because they're trying to make sure that no sick healthcare personnel come to work. And they're also making sure that everyone is wearing a mask. So I think that that's better. It's like when you go out to a restaurant, there might be someone there who has a bad cough and they don't care. They still go out to the restaurant. So I think that the risk is lower when you're going to a clinic or to a lab. So there's that is going on. But also remember, you still have to take care of your health. But if you can interact with your providers via phone or telehealth, I would do that. I would, instead of going face-to-face clinic, just ask them, is it okay if we just do a telephone or a video visit? And a lot of times it's totally fine. As far as the labs, you can certainly get your labs done, a time when there's not a lot of people around. And I think a lot of labs are trying to make sure that you're not sitting in a waiting room, with other people. And then if you're a transplant patient, I know that there are some companies that can come out to your house and draw your blood that way. But I don't know if that's even better. You're still having someone come into your house, but you still have to take care of your health. Certainly you can try to use telephone or video visit, to try to mitigate that risk.
Okay. One of the things that you mentioned early on in our conversation tonight was the issue that dialysis patients have with safe transportation back and forth to dialysis. Can you talk to us about how we do that in the age of COVID?
Yeah, that's really tough, isn't it? And I know I've also heard that some patients have a hard time getting transportation. Like especially if they have COVID-19, then no one was willing to pick them up, and they might even miss treatments. And I know that the National Kidney Foundation and the American Society of Nephrology have, sent a letter of concern, to the Department of Health and Human Services that's saying that, really need to make sure that patients can still get transportation to and from dialysis. But I would say, just make sure you wear a mask and ask them to wear a mask as well. So, and then just try to, use as much distance as possible from the driver is what I would suggest. But make sure that the driver is wearing a mask, because you wearing a mask is really protecting the other person. So you want the other people who are around you to wear a mask to protect yourself. So that's one thing I would say is never get in a car or bus or something if the bus driver and stuff are not wearing a mask.
I have read, Doc, that if you're wearing a mask and the other guy is wearing a mask, there's less than a 1% chance of transmission of that disease. Is that a correct statement, or is that near correct?
I don't know about that. I haven't heard about that. But I do know that, if you're wearing a mask, a surgical mask, then you reduce transmission by 50%. So I assume, like, if the other person is wearing a mask and they're it reduces by 50%, then maybe that could happen in 1%. I haven't heard that, But it does make a huge difference if everyone's wearing a mask. It's going to really help to reduce transmission of the virus. And then it also helps to make sure that people who have overt symptoms like a cough and a fever, because those people are the ones who transmit the most virus. That's the worst, is if someone is actively sick. So making sure that anyone who feels sick doesn't drive the bus and doesn't come to work, that also is another way to really help reduce exposure as well.
Part of the symptoms that you talked about, one of the other symptoms that you mentioned as a telltale symptoms in one of your talks is having the chills. Can you talk a little bit about that, please?
Yeah, so the CDC actually added that to their list of symptoms, I think something like a month ago, because first they were really focused on like fever, cough, and shortness of breath. But they found, that the way that people exhibit symptoms from the COVID-19 is really variable. So I know some people that all they had was maybe a little bit of fever, chills, and diarrhea. Other people might have had just like a dry cough and no fever whatsoever. But a lot of people do have chills. So even if you don't have a fever, you may just feel like you're developing a fever and you have the chills, but your body is able to fight off the virus. You never develop a fever. So that's one thing to think about. So like unexplained headache, especially like headache with chills, think about that. Sore throat. You can get like enlarged lymph nodes underneath your chin here, which would be that your body's trying to fight off that virus. Usually the cough is going to be dry. You're not coughing up a lot of stuff. It's just a dry, nagging cough. And fever would be something that would really make you think that you may have the virus, because most colds and stuff we don't get a fever with it. But I think especially like if you're a transplant recipient, you're on immunosuppressants, you may not get a fever. So if there's any change in your health status, consider the COVID-19 and think about getting screened. So like if you were doing fine, all of a sudden now you had chills and maybe body aches, think of the COVID-19. You may not ever get a fever.
Okay, very good. Thank you. One of the other items discussed in the letter, and we talked about the NKF's petition a little bit tonight before you were on the air. We talked a little bit about the safe resumption of elective surgeries needed for dialysis access, peritoneal dialysis access, decedent kidney transplants, for example. Can you talk to us about the need to resume these elective surgeries, or so-called elective surgeries?
Right. So I have, like, for example, I have a patient who around March was scheduled to get her AV graft kind of redone, because the first one that they put in, it caused like a Steele syndrome, and she wasn't able to use her left hand anymore. And she had a lot of pain. And it was something that I considered to be really an urgent and necessary surgery. But because of the COVID-19 epidemic, it was put off. And so this person then, has persistent pain in her hand. She can't use her hand, and then she has a catheter in. So I was really upset that surgery got delayed. But those are the types of necessary surgeries that many of our patients need, and we need to make sure that they can obtain those surgeries in a safe way without getting exposed to the COVID-19 virus. So this really requires hospital systems to implement efficient testing of the virus, so that if you're going to be admitted to the hospital, you're tested to make sure we're not bringing COVID-19 patients into the hospital and you don't know it, and they're sitting in a shared room or something, or going into an operating room and contaminating an operating room and the surgeons and things like that. So it requires like a systematic approach to make sure that people who come in for elective surgeries can obtain it safely. And so that requires help from state and national governments to provide guidance on that. So that's one of the things that we ask the Department of Health and Human Services to really help with that, to make sure that our patients are able to get these necessary surgeries, like getting PD catheters placed or replaced, getting fistulas and AV grafts, and getting transplants as well.
Okay, thank you, doctor. Please talk about the importance of ensuring that hospitals and dialysis centers have enough of an adequate supply of dialysis equipment and solution to provide for dialysis patients.
Right. So, so there's really an issue of the fact that I think people were not anticipating the high rate of kidney failure that would occur in these really sick patients in the ICU with COVID-19. So, so it really kind of, I think, surprised the community. There was a lot of emphasis on making sure we have enough ventilators, but what they didn't think about is the fact we also need enough dialysis machines. And then for the dialysis machines, a lot of them, if you're too sick to do the regular dialysis, then you need the slow dialysis that requires these big bags of fluid, and you can go through like 12 of those bags a day. So, so we found that there was somewhat of a shortage, especially in certain areas that were hit very hard, like Brooklyn or places like that. So we have asked them to really help with this, because it's sort of like a complex interplay of making sure you have enough of the supplies and the machines, because there's only 2 companies that make the supplies and the machines, and it's not like you can just, upregulate the number of those machines available to people. They're expensive. So we really need help from HHS to ensure that there is enough supplies as we have these, uprising of COVID-19 cases across the country. So, there is a way that you can kind of, you can ration things a little bit, but that's really not what we should be doing. We should be making sure that we provide the best possible care for all of our patients who have kidney failure. So I think that the Department of Health and Human Services really understands the problem, and they're trying to address it to try to help make sure that we have enough machines and supplies for that we can share across the country.
Okay, Doc, talk to us a little bit about what risk stratified means and high priority means when it comes to testing of kidney patients.
So risk stratified or high priority just means that you're trying to pick out those patients who have the highest risk, and you're trying to really protect those patients first. So you're trying to really prioritize. If we have a limited number of COVID-19 test kits, who should we screen first? So I would argue that we really want to try to look at those populations who, if they get the disease, they may have a high risk of doing poorly. So the NKF and ASN have really advocated to try to really focus on patients who have kidney disease as a population that is vulnerable for bad outcomes with COVID-19. So it would be great if we could screen all of the dialysis healthcare workers so that we could find those who are positive and isolate them and get them away from the patients. And the same thing with the patients. Like if we find patients who are positive for the virus, that we make sure that we, get them quarantined away from those patients who don't have it, to try to limit the spread of that virus among our patients and our healthcare providers. So that's why we say risk stratified is to really try to look at the patient population who is highest risk or vulnerable, and that would be patients who had a kidney transplant or who are on dialysis, or even those who have non-dialysis dependent kidney disease.
Okay, let's talk about vaccination and vaccines for a minute, Doctor. One of the points that you have made is that it's going to take 12 to 18 months for a vaccine to be developed. When it's due or when it's ready, because of the susceptibility that kidney patients have, they should be, quote unquote, first in line to be vaccinated. Can you explain that, please?
Right, so that all goes to the vulnerability of the population. So in addition to that, we should, test these, we should really try to do a lot more testing so that we limit the spread of the virus. Once we get the vaccine, again, we need to go back to our vulnerable patients population and try to make sure that they get the vaccine first. So we shouldn't be, going around and vaccinating healthy young people who have a very low risk of bad outcomes with COVID-19. If we have a limited amount of vaccine, then we need to really prioritize the vulnerable patient populations and make sure that they get it first. And that would mean patients with kidney disease should be vaccinated first in line. Absolutely.
Okay. Steve, how are we doing for time? Are we okay for time, Steve? All right, let me ask this, Doc. Okay. I was at a kitchen cabinet meeting recently with, Steve says time's okay. I was at a kitchen cabinet meeting recently for the NKF, and one of the things that was brought up is the patients that have developed COVID and then ACI as a result were placed on peritoneal dialysis, and then they were sent home. Unfortunately, they may or may not have had adequate training. They may or may not have had adequate supervision at home. Can you speak to that a little bit? What safety measures should be implemented to improve home dialysis for these type of patients?
Yeah, so I think, when this epidemic started, I mean, we're all sort of just learning as we go. We're learning about the virus, and we're learning how to deal with the kidney failure that came up. And so I know in some areas, many patients who developed kidney failure because of COVID-19 got put on peritoneal dialysis in the hospital, or when they were discharged, they were put on peritoneal dialysis in order to keep them at home. And certainly, as you said, it's really, really important that people know what to do, right? So if you don't know how to do the peritoneal dialysis and you do it wrong, then certainly you can develop an infection and you're just going to end up back in the hospital. I know that there are many organizations that are really trying to rev up education of professionals about peritoneal dialysis, and there's been many free webinars that have been offered by several societies to try to do better training of healthcare personnel on how to train the patients on home dialysis. But I also think it would be great if we could try to get more healthcare personnel to maybe visit a patient a couple times after their discharge to make sure that they are doing okay with the home dialysis. That would be super. That's not in place right now, but I think that's something that we should think about advocating for if we're going to be using a lot more home dialysis. And many patients may not feel comfortable if it's started very rapidly and they don't have a lot of training. But that is a difficult problem.
Okay. Doc, we talked a lot about elective surgery, and I noticed in the letter there's a term reentry guidance. What does the term reentry guidance refer to?
So reentry has to do with the fact that we've been in quarantine now, where we're social distancing ourselves and businesses and stuff are not open. But reentry is then as we start to reopen restaurants, we start to open businesses. And people are starting to kind of come out of their houses, and so there's going to be more risk of exposure to the virus for all of us during reentry if we don't do it safely. And so we really need to think again about our vulnerable patient population when we start to do reentry. So that's why I'm giving advice to patients who are on dialysis or who have a kidney transplant to maintain that social distancing, stay at home as much as possible during reentry. So while everyone else may be going out and getting their nails done and their hair done, if you're a dialysis patient, you're a transplant patient, don't do that. You need to continue to stay at home to protect yourself. So reentry just means kind of like the opening up of the businesses and the communities again.
Okay. Doc, we've talked a little bit about medications and the 90-day rule with sending medications to kidney transplant patients. In the correspondence, the May 20th correspondence, there's reference to an extension of time for an emergency period of this 90-day supply period. Can you explain why kidney transplant patients might need an extension of time?
Well, you're talking about the 90-day rule extension?
Yes, yes.
Yeah. So all that's just saying is that, we don't want patients during, the COVID-19 pandemic to be having to go to CVS pharmacy or Walgreens or whatever pharmacy every 30 days. It makes no sense. So we asked for all medications then to be a 90-day supply so that people aren't having to, get out of their house all the time. So some of these rules, it seems so silly that we have to argue for this. It seems like, we shouldn't have to advocate that. This seems like common sense that all medication supplies should be maybe even more than 90 days during the pandemic. Maybe we should give out a 6-month supply, in order to help patients avoid having to come out of their house and expose themselves.
Okay. Doc, one final thing I wanted to talk to you about and to plug. At the beginning of the show, I talked a little bit about the petition from the National Kidney Foundation. Can you tell us why this petition is important and why all our kidney patients and people affected by kidney disease should sign this petition?
That is so great that you're talking about the petition. So last I heard, we had 5,000 signatures on that petition. And I think when I was first talking about it, there's only like 1,000 people that were on the petition. So I think you've done a great job in getting the word out about this petition. But the petition is really is saying all the things that you've talked about tonight, about how we are a vulnerable patient population and that we need to be protected, and it's just really advocating for the kidney disease population during the COVID-19 epidemic, right? So it's saying that they need to be protected, need to make sure that you have access to the surgeries that you need for your health, and that when there is a vaccine, you be prioritized to get that vaccine so that you can then hopefully return to a normal life again. So that petition is incredibly important, and the more the people that are on there, the bigger that vote looks like, the stronger that group looks like. So if you haven't yet signed that petition, please go and sign that petition and ask your family members to sign on. It's incredibly important. I'm so glad you're talking about that. So do you have like a link to that petition that you're sending people tonight, or?
We'll take care of that, Doc. Oh, there it is. We'll make sure that people get that link. And I just wanted to point out some of the things that are discussed in that position: access to PPE, prioritizing testing patients in nursing home, critical elective surgeries going forward, 90 days of medical supply, non-emergency transportation, resuming safe organ transplantation. These are all important things to kidney patients and to kidney advocates. So please sign, share, encourage others to do the same. Doc, I'm out of questions. I appreciate you taking time. I'm sorry this went a little longer than what we anticipated. Thanks to Steve Belcher and the Urban Network for letting us go a little bit over. And I greatly appreciate the president of the National Kidney Foundation coming on with us tonight to talk about kidney advocacy. Appreciate it so very much, Dr. Holly. Thank you.
Thank you. Stay safe.
We will. Have a good night, everybody. Steve, we're done.